moving on, just a couple other housekeeping things. Number one, we do have a Twitter account for this particular conference, so it is hashtag Mosh Endurance, all lowercase, so hashtag Mosh Endurance, and it's a live feed, so we could get things going there. Also, the slides will be available for 3 weeks on the Mosh website. So they'll be there. After 3 weeks, we take them down. You also had them emailed to you, so you can certainly use those for as long as you like. And also the survey that will be online that you guys can access will come out after the first break. And so if you could, please fill out the session as you see moving forward, but don't fill it out too soon and hand it in, because then it looks like you didn't stay for the whole thing. So make sure you fill it out. You can hand it in after the whole session is completed, which would be no problem at all. So we're going to move on for our final presenter before our break, who had an awesome pleasure meeting last night. He was just full of energy. I feel like I'm going to have to work out a little bit better, certainly eat better. It's just, I just had a wonderful time with Dr. Sara Kotschi. She did both her Bachelor of Science and her doctorate in PT at Carroll University. She is a clinical and academic instructor at Carroll University, and she's also certified in women's health. She does dry needling. She does vestibular rehabilitation. She has an amazing talk that's coming up on physical therapy treatment of all the wonderful things that Dr. Spielitz just talked about. So without further ado, thank you so much for being a part of our conference. This is Dr. Kotschi.
I'm well aware that I'm the last talk before the break, so I am going to try to keep it moving. And I'm also going to try to avoid a lot of the redundancy that probably is going to come from piggybacking off of the previous presenter, Dr. Spielitz. So really, this title should say physical therapy treatment, but it also could be sports medicine professional treatment, because I see a lot of athletic trainers here as well, and we all really will be working together with a lot of these different athletes. So this is all of us right here. Now, again, to avoid redundancy, I'll probably focus more on what the evidence is showing in terms of more successful treatment protocols for some of these common injuries. We'll talk a little bit again about the difference between tendinitis and tendinosis and how that might affect what you are initially prescribing. But bottom line is that once we as rehab professionals are getting them pain-free and starting to transition to return to sport, we want to make sure that we are starting to incorporate more functional movement-based exercises to prepare them. And I know that our AT Claudia is going to talk quite a bit about that. Now, overuse injuries themselves, most of the time when you're taking the history with these athletes, they're not going to have a mechanism of injury or an event that they can correlate with their symptoms. This is much more the insidious onset. So when you're taking your history, a lot of the times it's a vague increase in pain that has kind of probably persisted over several months, usually involving the more mobile joints of the body. So we're talking the hips, shoulders, ankles, knees, that sort of thing, in addition to the weight-bearing types of joints. Big risk factors obviously can be like bony malalignments, it can be imbalances in muscles and strength. A lot of the times though, it's training errors. This could be just increasing your mileage too quickly. This could be switching out equipment and not having it properly adjusted, or having a nice rotation as you transition from one pair of footwear to the next. And those are the things that are going to require lots of education. As we've already touched upon, tendinitis is an acute injury. This is caused by an acute tensile stress to the tendon, and in doing so, you do have that micro tearing that occurs. So these are the athletes that did have an injurious event, and they can clearly tell you something that they did that caused their pain. We talked a lot about tendon structure just previously. The biggest thing that we need to remember as healthcare professionals is that when you're looking at the dense connective regular tissue that makes up a lot of those structures, we don't have good healing potential in them for two reasons. The first being that when you examine that tissue under a microscope, you don't see a lot of fibroblasts. So therefore, the healing potential, the repair cells are lacking in that tissue to begin with. And also, when you look at like cadaver studies, you have tendons that are a nice white, pearly color due to the fact that there is a paucity of blood flow, as compared to like beefy red tendon, or excuse me, muscle tissue that does have that blood flow present. So now, healing time ranges in the acute stage. If you catch it early and you rehab properly, it could only take a few days where you have pain and then you can start to progress more rapidly, or it can take up to 4 to 6 weeks depending on the extent of the damage. However, going into the more chronic tendinosis or tendinopathy, as we've already discussed, this is the insidious onset that usually has been happening over a period of months. And sometimes when it first starts, the athlete is only talking about pain during performance, but as things continue to worsen and there is that breakdown of that tissue, you're going to start to have more complaints with more day-to-day activities or even at rest. When you actually look at what that tissue is compromised of, like when they do tissue samples, we have a lot of immature collagen cross-linking. We have an increase in ground substance, so you actually have more space between the fibers as opposed to really normal healthy tissue. And you have abnormal vascularization of the tissue itself. So in some of the pictures that were in the previous presentation, there were a lot of comparisons on the diagrams where a healthy tendon has that white color, and then the unhealthy chronic diseased tendon has more of a brownish color from all of those tissue pathological changes that can happen with those chronic conditions. And because we are dealing with a tendon that has an impaired ability to heal itself, the timeline increases. So now we're talking about 3 to 6 months, or maybe even longer, again, depending on how long they've been struggling with this condition. General rehab considerations are pretty similar across the board. It doesn't necessarily matter in terms of healing if it's a shoulder or a knee. The bottom line is that we want to improve the loading capacity of the affected tissue. Taking a history is important simply because depending on the stage that the athlete is presenting, it might affect initially what you might counsel them. So for example, acute injuries, when there has been an injury and we know that there has been an inflammatory process that started, those are the people that you can counsel on the anti-inflammatory strategies. Those are the people that are probably going to have the best benefit from taking the NSAIDs, my personal favorite being Aleve. But those are also the ones that you can caution on. Maybe you're going to ice a little bit after an activity. And in the early stages, if it is acute, those are the ones that maybe rest initially is going to be okay. However, with the chronic conditions, we want to facilitate tendon repair. We're not necessarily encouraging anti-inflammatory strategies because that might unintentionally be delaying the progression to the proliferative phase, to actually getting new tissue to build. The broad timeline, and this is what you need to educate your athletes on, is how is this going to look? If you focus solely on pain, and you tell an athlete, okay, we want to address your pain, that's great because that's why they're there. But if the athlete perceives their pain to be better and they think that therapy is over without having had spent sufficient time addressing all the other biomechanical impairments, you might be setting that athlete up for failure. Because if they're only basing their potential on how much pain they feel, all those impairments that you might have identified in your evaluation, things like muscular imbalances, malalignment, flexibility issues, those might go unresolved, and then those are the athletes that might go back to the doctor with the same thing over and over again. So as sports medicine professionals, we really should be hopefully educating our patients that not only are we addressing your pain, but we're trying to do a full body treatment to bring you back to sport and to the best performance potential, especially considering the fact that the incidence of re-injury can be quite high, especially in some of these high endurance athletes. The general protocol, we're all very familiar, I think, with this. The idea is that first we're going to reduce your pain, we need to improve strength, we need to build the functional strength, closed chain strengthening activities, full body movements, challenging the stretch shortening cycle, which is the idea that if you're about to perform a powerful movement, there is an eccentric phase, amortization, and then concentric power explosion. So by challenging that cycle, again, you are setting them up for a more functional movement. And then finally, you want to target the sport-specific movements. You want to make sure that you are including activities that do speak very much to the inclusivity of that sport itself. Now, when we look at tendinosis, because it is more chronic, I do think patient education should be the first and foremost thing that you treat or target. You want them to kind of move conservatively. We've already kind of hearkened to this. A lot of athletes, when they're higher level, aren't going to want to be told that they need to rest. And unfortunately, the research doesn't support rest for some of the more chronic conditions, because if the athlete is resting but the healing potential hasn't progressed, not only are they not healing the actual injury, but a lot of people might feel like they're deconditioning, which is the exact opposite of your goal. You want to get them back to performance. So this is where you might want to look into the cross-training and maybe even bring the coach into the discussion as to, okay, we need to alter the mileage, we need to alter the training plan, and we need to find different ways to challenge this so that they are getting that cardiovascular challenge while still resting the tendon appropriately. Now, ad nauseum, we're going to talk a lot about biomechanics, we're going to talk a lot about how you have to treat the whole athlete. The biggest other thing with tendinosis is that we do want to stimulate fibroblast activity. Again, we want that healing to occur, and you want to stretch or challenge the tissue appropriately, but along the lines of stress. I.e. the idea that if you are going to be performing in a certain range of motion, you challenge that range of motion so that the fibers, when they are putting down new cross-linked collagen, it is in a nice, smooth pattern, and it is not abnormally cross-linked or in that lattice formation of unhealthy tissue. And then finally, eccentric strengthening, again, also something that has been found to help promote healthy collagen cross-linking. So some of the common conditions that I wanted to talk specifically about, again, we know how to generally treat tendinitis or tendinosis, but these are some of the bigger ones that you might see in your practice. Now, with medial tibial stress syndrome, for all of the direct access practitioners in this room, the biggest takeaway is that there could potentially be some other things that are contributing to that, like kind of anterior shin pain. So if you are seeing an athlete that has not been screened by a doctor and it is a direct access situation, you should make sure that stress fracture isn't a part of their pain source. And then more than ever, I'm starting to see in my practice a few more people with that kind of chronic compartment syndrome, not acute per se, but again, it would change your plan of care and maybe even necessitate referral for some additional counseling. But the biggest thing with medial tibial stress syndrome is that in the acute phase, when it's just starting up, rest is supported. In the literature for some improvements, maybe just about within the first week, you could have them rest and take it easy. And then you could potentially use a few of the modalities. However, when I was actually looking for studies that supported them, there hasn't been much that has been efficacious for that level. Most of the time you can just counsel them on the price and said anti-inflammatory strategies, and that is good. When you get to subacute or the more chronic, this is where that activity modification can be particularly important. One thing I've always kind of talked to patients about is that if we need to reduce running mileage and we need to reduce the amount of time they're pounding the pavement, there is a nice ratio for like cycling to running mileage. You could do 3 cycling miles for every 1 mile of running that they need to accomplish. So if the coach is on board and they say, well, we were hoping for 25 miles of road running this week, you could reduce that to maybe about 20% that with road running with brakes, but then increase cycling mileage with that ratio to hopefully achieve the same cardiovascular stuff that will still challenge their endurance. Then we really need to be considering what's going on up the kinetic chain. A lot of the times, success for long-term rehab for some of these overuse injuries needs to be considering proximal muscle strength, core, glutes, hip external rotators, all of those muscles, and maybe even pelvic floor, especially for the female athletes. Patellofemoral pain syndrome, as we've already talked about, the exact etiology is not necessarily known, but there is a host of biomechanical things that we really need to be considering that could affect alignment and patellar tracking, especially with like muscle imbalances, flexibility, or strength. Conservative management is first choice, though. There hasn't been any additional benefits in the research with people that have had to get surgical intervention. So we do want these types of conservative treatments. The biggest thing with the research is that multimodal, where you're really looking at all of these different assets, that's where you're going to have the best long-term success. So we want to reduce the pain, we want to address the mechanics, the footwear, the training frequency. And going back to what we had just heard, 80% of studies did find improvement in knee pain with just route knee strengthening exercises. But there were studies that took it a step further and went higher up and did a lot of like core conditioning, looked at the back, looked at the pelvis, and did that. And they found in particular during the acute phase that the proximal strengthening helps to reduce the load on the tendon itself and is still challenging the athlete so that they're still doing functional rehab and resting the tendon and progressing towards pain-free return to sport. So here's where I'm gonna talk about the new evidence and the challenges to what we had previously thought about this syndrome. Back in 2007, there was a host of cadaver studies that were being performed to actually look at just how movable this IT band tendon really is. The first thing they found is that tendon is almost a poor choice of a descriptor because it actually has fibrous attachments to the pelvic itself, so it's almost like a tendon ligament. So that was different. They found that there were a number of fibrous attachments throughout the femur, blending into the capsule of the knee, and also along the vastus lateralis of the quad. In 2012, there was a new ultrasound study that was released that did show a little bit of like sliding movement over the condyles with flexion and extension of the knee, so there is some movement that's occurring there. But then going back to those same cadaver studies, they didn't find a lot of bursa evidence. They theorized that if there is any like localized inflammation, swelling, or fluid collection, that might be due to irritation of like a fatty kind of tissue as an insulatory mechanism. It's not necessarily a bursa. We might not actually be treating a friction syndrome. But then what do we do? As far as the actual research itself, there's not a lot of high-quality studies that look at IT band rehab. Most of the evidence or the things that we're doing are anecdotal. But foam rolling itself has been found to like temporarily, locally increase perfusion and mobility of the tissue when you've done it, but again, it's temporary. It could only be a few hours. There are some studies that found it lasting a little bit longer, but that might be why some people find temporary relief in their symptoms, but it's not necessarily something that helps them get over the rehab hump in and of itself. If you're stretching the IT band, again, the evidence just really isn't there. I remember back to my school days when I was in cadaver labs, I was working with an instructor on the hip. We were trying to disarticulate it, and I could almost pick up the entire leg using the IT band as a purse strap. It kind of struck me then, more than ever, that I don't think we're stretching this the way that we think we're stretching it. Really, more and more evidence is coming out, and in particular, 2 really good case studies that are included on my sources page that are worth reading about, where you're looking more proximal again. In the 2 case studies that I found, they looked at low back. They found that the 2 athletes, and they were higher level female athletes that had chronic IT band issues, they also had a history of low back pain that just never was asked about in previous rehabs, that was never addressed in previous rehabs. They found alignment issues, they found hypertonicity of the quadratus lumborum, they treated proximally with strengthening and alignment, and those athletes were able to return to sport with no instances or recurrence at that point of those case studies. The other thing is that when you're looking at all of the muscles associated with IT band, we're finding more and more success with treating gluteals and TFL. So I'm a dry needling specialist. My colleague Erin is going to talk to you a lot about dry needling today and some of the very exciting things we've been able to provide athletes with this treatment. Trigger point referral patterns, though, you don't need to be a dry needling specialist to be really good at recognizing and treating. So here are the common trigger point referral patterns for all of the musculature around the IT band. We've got TFL, the obvious one that feeds into the IT band itself, and then we have glute med and min in the middle there. Also a common complaint for people with like radiculopathy of L4, L5 or sciatica. And then finally, one of my favorite ones to needle, at least the first treatment, is VL. Again, hearkening back towards the cadaver studies with all those fibrous attachments. Plantar fasciitis, another common complaint. Again, ad nauseum, looking at the mechanics, looking at footwear, treating up the kinematic chain to try to address those symptoms. But we also should be looking at trigger points. Looking at gastroc, especially medial head, look at that big referral trigger point pattern right on the bottom of the foot. Every once in a great while, we might have a client that comes in with plantar fasciitis, but when you're palpating that area, it's really difficult to elicit the pain response. Check up into the calf. You might be surprised what you find. Other muscles that can be really efficacious for this would be abductor hallucis within the arch itself, and then quadratus plantae, the very bottom foot. Modalities-wise, again, ultrasound is kind of losing out on this, but iontophoresis, surprisingly, actually has some pretty good research behind it for helping to address any acute inflammation. And then finally, muscle strains. Now we're moving away from the connective tissue component. We're looking at tissue that is contractile. For acute strains, the Price guidelines really do work well, and you want to have the athlete working through just pain-free range of motion, best as they can. Then, after 2 to 3 weeks, and they're starting to have some of those acute pain symptoms to decrease, you can start the very, very gentle strengthening along, again, the stress lines to help facilitate tissue healing, strengthening within pain-free limits, and the biggest thing, I think, proprioceptive training. Most of the time, if people are having strains, it's an overstretch strain, so you always should be thinking to yourself, how well does this athlete work within their range of motion? Proprioceptive training should be key. Once the athlete has full pain-free range of motion and 90% of strength returned bilaterally, that's when you can start to look at progression to return to sport. Now, thankfully, Claudia is going to get in here and talk at length about all of these progressions, but the biggest thing is that as sports medicine professionals, we're really hyper-focused on pain and impairments, the things that we identify in our evaluations, but we really need to make sure that we are treating the athlete themselves and that we are designing our interventions with that in mind. We can tailor our treatments to the specific sport or to the specific endurance athlete's event. And if we do that, I think we would have better adherence to the training program in general if we're including those aspects into our treatments. So one of the best tools I think we have as healthcare professionals is motion analysis. We should be making sure that we're looking at how the athlete moves, breaking down the sports into individual components, and then making sure we design our treatments around that. So the bottom line, how does this apply? First and foremost, we need to address their pain, but we have to educate them that their rehab is beyond the pain. There are other factors that we need to address, like range of motion, strength, mechanics, proprioception, and then finally getting them back into their sport. That was the fastest 20 minutes of my life. Thanks, guys.